I'm a gynecologic oncologist, meaning I'm a female cancer surgeon. But the great thing is that being a doctor, I also get to do a lot of research. And so I'm very grateful for that opportunity. And a lot of my research has been primarily involved in cervical cancer and primarily cervical cancer disparities. And so we're going to go over some of that today and kind of, obviously this is a hot topic right now and we're seeing a lot of changes. And so I'm going to go over some of the areas where I think, there's going to be some changes, but I think we can still do this work. And I think it's very important work. So Dr. Shrestha asked me just to kind of briefly go over my trajectory to how I ended up here. So I'm originally from New Mexico, grew up there in a very rural, underserved area. And so I've always been passionate about working with individuals who are don't have access to healthcare like most people do. And went to college there, did my biochemistry degree, loved biochemistry, wasn't sure if I was going to go to medical school or not. I actually took a year off in between undergrad and college or in medical school and traveled the world, did some volunteer work and really figured out that medicine was kind of the way I felt like I could impact the world around me. So then went to medical school, did my research in medical school is actually over in Uganda looking at empowering women and trying to decrease disparities in HIV transmission from mother to child and actually showing that when you empower women, they're willing to take medications that then prevent the transmission of HIV vertically. So came here, did an OBGYN residency, that's 4 years, then did a gyn-onc fellowship. So specifically now I just primarily deal with women who have cancer, do their surgery, do chemotherapy afterwards, and then also do research in trying to prevent cancer so I can get myself out of a job in the future. So today we're going to go over a few different things, and I'm going to take this opportunity to do some education about cervical cancer. I'm going to get a little bit on a soapbox and kind of share my passion and why we do the research that we do, and then go into some of the research that we are doing currently and will continue to do moving forward. And please, if you guys have any questions or any clarification, don't hesitate to raise your hand, interrupt me during the talk, because I'd love to make sure you understand kind of what we are talking about. I have no disclosures. No one pays me to do this. I mean, I get paid by you to be a doctor, but like no one pays me to come and do these talks. I don't get any industry funding. And so anything that I'm talking about today is just purely data-driven stuff that I think is important. So first off, cervical cancer is the third most common gynecologic cancer in the United States. There's about 14,000 cases new each year and about 4,300 deaths. You can actually see there's a pretty high mortality rate compared to the incidence of this cancer. So we know that it tends to be a more aggressive and not a very nice cancer once you actually get it. When we think globally, it actually has a much higher rate, and it's the second most common cancer in women, or maybe third most common cancer in women globally. So not even just gynecologic, but in women globally. And that's just because they don't have as much access to Pap tests and HPV vaccination. Sorry, fourth most common. I apologize, it's right there on my slide. The average age of diagnosis is around age 50, although I will say I think this is going down slightly, meaning that younger women are being diagnosed more commonly now. And then estimates of incidence and mortality for cervical cancer vary, but we know that the highest incidence is actually in Hispanic women, and then the highest mortality is in Black women. And so these are issues that we're really passionate about, because why is the incidence higher? Why is the mortality rate higher? And how can we address those issues so that we can make sure everyone has equal access to care? So how do we get cervical cancer? It's caused by something called HPV, the human papillomavirus. There's a bunch of different types of this, and it does not just cause cervical cancer. So and then most individuals at some point in time, if you're sexually active, will be infected. About 80 to 90% of people, most people clear the infection on their own, but when you don't, that's when it can cause either precancer or cancer. It can also cause head, neck, and throat cancers, anal cancer, vulvar cancer, penile cancer. Obviously, today we were just talking about cervical cancer, but this is not a female-only problem. Males can be affected as well. And you see that number there, that there are 46,000 HPV-associated cancers each year. We just said the incidence of cervical cancer was 14,000. So you can see there are a lot of non-cervical cancer-associated HPV infections that lead to cancer. And so that's why it's so important for all individuals to pay attention to this issue and to get vaccinated. You can see here there are several different types that are associated, and that really just gets into when we do screening, we look for these specific types that are higher risk for causing cancer. HPV, the risk factors for getting cervical cancer has a lot to do with sexual activity and how much of it and Also, if you're immunosuppressed in any way, shape, or form. So one of the grants that I'm working on with Dr. Shrestha is looking at individuals who have HIV. A lot of times they get infected with HPV, and then it's very difficult for them to clear the virus because they are immunosuppressed. And then other significant factors are heavy tobacco use. So I always counsel my patients making sure that they quit smoking, and then lower socioeconomic status. So when we think about cervical cancer, one of the most important things we're going to talk about is, and this all goes into the research and why we do it and how we do it, but so everyone knows what screening for cervical cancer is. It's a pap test. So you go to your doctor, you get screened for HPV, you see if you have abnormal cells. The whole goal is to try and catch it before it turns into cancer. So sometimes they'll see these abnormal cells on a woman's cervix, and then they'll say if it's either can be this range from normal to cancer. And so it's this very slow progression that the HPV will slowly attack the cells on the cervix until it becomes slightly abnormal, very abnormal, and then it can eventually turn into cancer. So a lot of times when it's low grade, we just watch a woman. If it becomes high grade, we'll frequently treat them, which I'll show you in a second. And then once it becomes cancer, obviously we have to do something. So this is our PAP screening. Less than 21, we don't recommend it. Over 21, we recommend it every 3 to 5 years, depending on what you have done. But I think the most important thing for you guys here today, even if you're not in the hospital, even if you're not working with patients, you have a voice as well. And you talking to your family members and ensuring that everyone you know is being screened, or at least has seen a doctor, is extremely important. And I cannot emphasize that enough, knowing some of the women who have come into me, the only reason they ever came in is because a family member told them to get checked out. And if we start doing it earlier, encourage the people around us to do it, we can prevent it before it turns into cancer. So you guys have a very important voice. Make sure you yourself are getting screened, and that the individuals around you are as well. So if you do have an abnormal finding and it's more of a high-grade lesion, we do something called colposcopy. I tell everyone we basically look with a microscope at the cervix really closely to see if there's any abnormal lesions, and we take a biopsy. If it actually comes back as a precancer or an abnormal area, we do something called a loop excisional procedure, meaning we just resect a larger area out to try and get rid of all those abnormal cells so then the cervix can heal itself. So this is one way we can prevent cervical cancer. We do the pap test, we find the abnormal lesions, and we excise them to try and get the cervix to heal itself before it turns into cancer. The other way we can prevent it is through the HPV vaccine. So this is complete prevention. You get HPV vaccination, and then the whole goal is that you don't actually get HPV. If we live in Alabama, there's a lot of vaccine hesitancy. And so it's really important to know what type of vaccine it is, because then you can counsel people better. So this is a vaccine that uses virus-like particles. It's not RNA, it's not DNA, and there is 20 to 30 years of data on this type of vaccine. So it's not a newer vaccine. It is very well known. It is very well tested. The rate of adverse events is 0.04%, so very low. And we know that it works. So I'll show a slide in a little bit, but when a community undergoes HPV vaccination and you get enough of it, you get kind of this herd effect. And in Scotland and a few other countries, we've actually seen basically almost the elimination of cervical cancer in the subgroup of women who got vaccinated by the age of 14. And so there are 3 different types of vaccine, but really the one you guys will hear about is Gardasil 9, and that's the most common one that we use. You can see here that it has the 2 more common types of HPV that cause cancer, so both 16 and 18. But it also actually protects against genital warts. So HPV 6 and 11 both can cause that. And so this protects against all of those things. When do people get HPV vaccinated? So obviously we're all over the age of 12 in here, but for kids, we do recommend kind of starting vaccination around the age of 11 to 12. You can get vaccinated as early as 9 years old. And now you can get vaccinated up to the age of 45. So it used to be 26. But now there's this realm between, we still know that there is some utility between the ages of 26 and 45, because people who are, still out potentially having more sexual relationships could be exposed to more types of HPV. And so it's actually really important to make sure, if you've not been vaccinated, to see if you're someone who may be at high risk and should get vaccinated. If you are a healthcare worker and exposed to HPV in that setting, so like I do a lot of work in the clinic or in the operating room and potentially could be exposed to aerosolized HPV. So I actually wasn't vaccinated as a kid. My parents, I don't know if we lived in rural New Mexico. I didn't even know if they knew it was a thing. So I got vaccinated when I was here as a resident. So it's never too late. I literally study this stuff and I was late to vaccination. So it's never too late. And if you have questions about that, I'm happy to kind of point you in the right direction where you can get vaccinated. And it's just something that's important. And this is another area where your voice matters, because make sure your friends, family members, kids, boys, girls, everyone needs to be vaccinated. And so it's always just something you can bring up. And studies show that people are more likely to get it if they hear about it from a family member or someone in the medical field that they trust. And so just an important thing to talk about. The HPV vaccine, the reason we recommend it for both boys and girls is because it prevents it decreases the rate of all types of HPV associated cancer. So you can see all the different types here, including head, neck, and throat, and then all of the female and male cancers as well. In Alabama, we're not the best and we're not the worst, but our rates of vaccination, you can see down here, are not fantastic. So we're kind of around 50%. I actually think this is a little bit higher now. I think we're around 65% or so. So we are moving in the right direction, but it's still important that this is an issue that we really try to stress. And so just like I said, use your voice. You are important to this cause as honestly as much as doctors, physicians, anyone else is, depending on where you work, and just make sure that obviously your family members are aware as well. So just a few more thoughts about HPV, and then we're going to go back into cervical cancer. But this is a common virus. It's spread by skin-to-skin contact. It can lead to a bunch of different types of cancer in men and women. Currently, there's no cure, although I will say we are working on a vaccine, and some of our they're in the School of Public Health, but they also help us out in the Gynecology clinic over here, help screen some of our patients to see if they're possible trial candidates to get this vaccine that we're looking to see if we can clear HPV infection in individuals to try and prevent it from turning into cancer. So currently no cure, but we are working on it. And then herd immunity is also really important. And so this is a cancer that we shouldn't even have to be talking about, because we can prevent it and eliminate it. But we will continue to talk about it, and we will continue to address the disparities associated with it until we get herd immunity and can, which leads to elimination. So now back to cervical cancer, and I'm going to kind of pivot a little bit into what some of our research is and why we're doing it, and how, as a School of Public Health, how as epidemiologists, no matter kind of what field you're in, how you could potentially tie into this type of idea, and how to maybe even create different projects about things that you're interested in. So cervical cancer happens because dysplasia, so the abnormal cells in the cervix, stay there long enough and then they turn into cancer. Cervical cancer is some cancers, when you think about it, you'll be like, oh, it's metastasized to the brain. This is a type of cancer that tends to just spread directly first. So it actually spreads out to the sidewalls of the pelvis. And a lot of women will come in with severe back pain or kidney failure because the cancer has blocked off their ability for the urine to go from their kidneys down to their bladder. And so a lot of times they come in with pretty severe pain and bleeding. And then eventually, once it's gotten large enough, it can spread to the other areas, including lung and bone and liver. Like we talked about before, it is a very aggressive type of cancer. So a lot of times, if we can catch it really early, we can cure it. But most of the other time, if it's advanced or has spread outside of the pelvis, then we're usually trying to kind of chronically manage it until it finally, the person passes away from it. So our main goal would be to try and to prevent it. And that's why the research that we care about so much is important, and really making sure that the disparities associated with it, so especially in Hispanic women, Black women, and people of lower socioeconomic status, making sure we figure out how to address those gaps in care. So what are our issues? We know that there's issues and differences of follow-up. So we'll go over that. We know that clinical trial enrollment is different depending on your access to care and kind of your knowledge base, and people actually coming and talking to you about the clinical trial. And then we're going to talk about some differences in outcome just in general. So the first thing we want to do, obviously, if you can prevent something, you want to raise awareness about it. And so with the HPV vaccine, this is a recent study. You can see it's from 2023. They looked at over 1,500 participants. Most of these were women. You can see there's kind of a spread. Most of the patients were white, some were Hispanic, some were Black. And overall, there were disparities in HPV awareness. This was more evident in people who had a lower socioeconomic status, and then also in some Asian individuals. And so we can see here that there's this gap in knowledge that people are receiving even information about HPV. If you don't know what HPV is, then why would you get an HPV vaccine? Why would you recommend this? Like, if you don't understand why it's a problem, then one, you're not going to get screened. Two, you're not going to get the vaccine. So that right there, baseline, we've got to improve education level and make sure that everyone understands what it is and why it's important. And why do we care? And what I talked about before, this was a study published, I believe, in 2024, so just about a year ago. This showed that women in Scotland who received the HPV vaccine before the age of 14, cervical cancer was eliminated in that subgroup. So all the women who got the vaccine before the age of 14 did not have any cervical cancer on their follow-up. So we know that the vaccine works, and that's why it's so important for us to make sure that we are educating people and getting people access to this vaccine so that we can prevent cervical cancer from even happening, and then also the other types of cancer we talked about before. This is where my area of passion really comes into play. So there's differences in follow-up. So Alabama actually has a really good rate of pap testing. We used to call it a pap smear. So if you hear me saying pap test and it sounds weird, it's because the terminology has changed, but they're the same thing mostly. And so in Alabama, the average rate of pap test is about 80 to 85%. That is actually at the national average. Both Black and white women are at that national average. But we know that Black women in Alabama have a higher rate of cervical cancer and a higher rate of mortality. The issue, that gap, is the follow-up. So women are coming in and getting their initial screening, but then when they have abnormal testing, they don't get any sort of follow-up. That then turns into cancer, and that's where we see that disparity. And so my current research that I'm just finishing up right now is looking at talking to women and figuring out, you had an abnormal pap, where was the gap and why you didn't follow up afterwards, and what can we do to address that gap? And so that's what we're trying to figure out and really make sure that every woman has access to what they need in order to be able to come back and get the treatment they need. I genuinely think it's an education issue primarily. And so we're looking at creating interventions to try and make sure that every woman has access to the proper education when they have pap testing. The next one is that we know that there is a difference in histology. So when we talk about histology, and this is a little medical terminology, but there are different types of cervical cancer, and some can be more aggressive than others. And so Black women tend to get the more aggressive types of cervical cancer. And so we're trying to figure out why is that as well. So why are they more likely to have these like adenocarcinoma, which can be more aggressive and can progress a lot quicker? And what can we do to try and, if we can figure out why that is, then hopefully we can treat it and prevent it from happening or catching it sooner. And so you can see here that, Black women had the highest overall mortality rates. And so this is another area where we're really trying to figure out why is that and how can we fix it. One of the things that we care about the most is that we know that when women have access to clinical trials, their outcomes are better. And so a huge topic in the field of gyn-onc, and it's not just cervical cancer, it's all types of cancer, is that a lot of white women get enrolled in these trials and then not a lot of other races. And that's a huge deal to us because I don't just see white women in the clinic. I see women of every, ethnic, nationality, race. And so if I'm going to offer them a chemotherapy drug, or if I'm going to offer them something, I want to know that it works in everyone and not just white women. And so one of the things that we're really trying to do is make sure we can eliminate these disparities and provide the opportunity for all women to get enrolled in clinical trials. So one, we make sure that they're getting equal access to care, but also so that we know that our treatments are being adequately assessed in all individuals. And so you can see here that there was a huge disparity in, honestly, there's a disparity in all women getting access to clinical trials, but definitely in people who are Asian, Black, or Hispanic. And so how do we fix that? How do we address that? This was something that Dr. Arend, Dr. Ha, and Dr. Leith, and then the rest of my colleagues were visionary in this, and I got to be a part of it, and I'm very grateful. And Fabiana right now gets to screen our ladies for us to be part of this, making sure that all women have equal access to care. So what they did is, it used to be for a clinical trial, us as physicians, and we're not very good at this, so it's honestly a lot of our fault. We would have to have all the clinical trials memorized in our head, know if our patients were eligible to it or not. In the middle of a busy clinic, remember if they're eligible, should we talk to them, all these. And so we didn't do a good job. And a lot of patients would be missed, or we would like forget about it until later. And so what Dr. Aaron and the rest of the team did is they said, let's take it out of the physician's hands because we know we're not doing a great job of it. And let's have someone who screens every single patient coming into our clinic. Does not matter who they are, what their background is, but every single patient who's a new patient gets screened and then gets approached in order to say, hey, do you want to be involved in this clinical trial? Here's this information. Yes, no, etc. And we actually found that that significantly increased our enrollment in general, but it eliminated disparities in our clinical trial enrollment. And so I think that's, one of the best things we have now is the ability for all women to participate in clinical trials. Now what we're trying to do, and my next research focus is actually looking at when women do refuse, why are they refusing, and what can I do to help make them feel more supported? There's women who come from 4 hours away. There's women who you hear clinical trial and you think, that sounds like you're experimenting on me. Like, I don't like that idea. And so how do we make it more approachable for women to understand that a clinical trial actually means we're trying to give you access to the best possible treatment that we think is available. And so working on making sure that we are providing education that is patient front and really that they can understand the access to it and what it means. And then the last thing I want to talk about is just the difference in outcomes and based on stage. And so this was something else we looked at. Alabama has one of the highest rates of cervical cancer, like we talked about before. And so unfortunately, that means that we have access to a lot of patients to try and look at these issues, but it also means that we have the opportunity to try and help come up with the things to solve these problems. And so when you look at cervical cancer, if you have early stage, your overall survival is about 80 to 95%. That's great. Someone comes into me with early stage cervical cancer, most of the time I can say, I'm going to do surgery, I'm going to take out the cancer, and then we're going to follow you. But if you have more advanced cancer, you can see here that their survival rate drops significantly. So 30 to 50%. And if you have stage 4, less than 20%. Those are 5-year overall survival rates. So that means, you come into my clinic, you have stage 4, the chance of you seeing next year is extremely low. And so that is why we care so much about trying to, 1, prevent it, but 2, catch it early. So one of the things that we looked at was, well, why do some women come in early? Why do some come in advanced? And are there differences in these 2 areas? And this is a small diagram, and I apologize about that, but I'll read off to you some of the reasons why women came in early. So we call these facilitators. So looking at research, you have barriers and facilitators are things that obviously help us catch something earlier. So women who had knowledge of the importance of having a Pap test. So again, coming back to that education component is so important. Public health, making sure people are aware of these things, having an abnormal Pap test. So there we go again. They had an abnormal test and they realized that meant something was wrong and they needed to go for follow-up. So again, having education. And then here, having a friend or family member with a history of cervical cancer. So that comes back to a woman sharing her history or sharing the importance of having follow-up. So again, your voice is very important. Barriers, when we did this study, was right during COVID. So there was a lot of delay, and I'm still actually seeing delays from COVID and women not getting screened and then coming in with cervical cancer. People feel embarrassed. People don't like coming to me as a physician. They don't like the exams. They don't like, it's not a fun experience for women. So they don't want to come in, but stressing the importance of this is actually something vital for your health and we can prevent it from becoming cancer, I think is, very important too, and comes back to the education piece. No insurance, obviously that's an issue. But I will tell you that the Alabama Department of Public Health, she does a very good job in this area. You don't have to have insurance for screening for either a Pap test or a mammogram. They can basically get you covered for both of those things if you get synced up with them. And then when looking at advanced stage barriers, a lot of it came from fear. So most women, they were worried about if I go in and see a doctor, they're going to find something wrong. I don't want to go to the healthcare system. And then some of them just didn't know about cervical cancer and had no idea that it existed, didn't know that it could be a thing. So again, that goes back to the education component of things. But, and then what brought the women in? their facilitator was that they had symptoms, but by the time most women have symptoms with cervical cancer, most of the time that means it's advanced, and most of the time that means that we're going to have to do kind of a more aggressive treatment regimen. This just kind of goes into more of the factors. So lack of knowledge, they felt healthy, so they didn't feel like they needed to see a doctor. Doesn't matter if you feel healthy, all people should have a primary care physician, or at least make sure they're getting their routine screening. Not having a perceived risk of cervical cancer, fear of going to the physician, and then not having insurance, and then being delayed because of the pandemic. So overall, what we found from this study is that we want prevention. We know that's the most important thing. It's really important to try and diagnose women as early as possible. The main barriers include insurance, lack of knowledge, fear, embarrassment, and then facilitators. Screening brought people in. That's why screening is so important. Friends and family and knowledge. And then, again, what we decided in this was that we need to figure out how to get patients to follow up after they have abnormal screening. And that was the study that we've just completed and are now analyzing the data. So what next? What are the things that we can do to continue to work in these areas? And so currently, we actually have some good press about Alabama. There's something called Operation Wipeout. And my mentor, Dr. Isabel Scarinci, is just a legend in the field of cervical cancer prevention, not only in the United States, but honestly globally. And her team and the Alabama Department of Public Health teamed up to create this campaign. It's the first campaign in the United States saying we want to eliminate cervical cancer. It's not, we want to make it better. We want to improve our outcomes. We want to eliminate it. And so it's an elimination goal. And you can see there was this article in the Wall Street Journal. For once, I swear to, we always have people coming down here from the Wall Street Journal, the New York Times, and they always want to do all these articles, and they end up making Alabama look terrible. And they act like we don't, want to provide good care for our patients. So this is like the first time where we've had some positive feedback. And so it is very true. So this is a statewide campaign, really calling every individual, no matter what your job is, no matter where you work, knowing the importance of cervical. That means all of you guys too. I'm putting you all on the spot. You guys are all now going to be ambassadors of this campaign. So knowing what cervical cancer is, using your voice to make sure that people are being screened with a pap test, increasing rates of HPV vaccination, and really trying to get women to come in for treatment as quickly as possible. And then finally, the other things we're doing, like I talked about before, we're starting a grant this summer looking at trying to improve clinical trial enrollment, and then also looking to improve follow-up after abnormal screening. So in summary, like we talked about, cervical cancer, it's the third most common gynecologic malignancy, mostly caused by HPV, and it's preventable. And so that's the key. And if you take nothing else away from today, just know pap test and HPV vaccination and how important they are. But that also this is an area that is ripe for research. There's a lot of opportunities and gaps in care. And so there's a lot of opportunities for research. And again, these disparities exist, and everyone has a part in helping eliminate them. And if you have interest in kind of this area or want to get involved in anything, please obviously feel free to reach out to me. I've always got a few projects kind of here and there going on. Or if you're interested in some other part of public health or, female cancer, reach out to me and see if, you want to get a project going or kind of work on something. I'm always happy to assist in any way possible. So I will take, and then I want to thank Dr. Teresa again for letting me come and talk to you guys about one thing, my research and just cervical cancer prevention, but also just working in the field of disparities, because I know that's kind of, a topic right now that is pretty heavy on most people's radar, and that type of research is going to probably look a little bit different, but it still needs to be done. And I'm going to continue to do it. And, I'll figure out, maybe I'll use a different term or something like that, but I'm not going to change how I treat my women in Alabama. And I'm going to continue to work on those gaps in those areas. And so I just encourage you, if you're feeling discouraged or if things feel different, this is still very important research, and we will continue to do it. We're just going to figure out how to do it. So anyways, thank you so much.